Well, good afternoon and welcome. Thank you for joining us for today's talk, From 1619 to COVID-19, A Racial Journey of the Road and Traveler, with Dr. Collins Airhihenbuwa. My name is John Keese and I direct Loyola's Office of Peace and Justice. This is the fourth installment in this year's Bunting Peace and Justice Speaker Series, which brings leaders, scholars, and activists to Loyola to address issues of timely relevance at the intersection of peace and justice. Last semester, we were delighted to host talks on topics addressing policing and racial justice, nonviolent resistance, and the recent genocide case against Myanmar at the International Court of Justice. Next month, on March 23rd, we look forward to hosting Esther Ann of the Cutler Institute at the University of Southern Maine, who will deliver a talk on her experience helping to convene the Maine Wabanaki Child Welfare Truth and Reconciliation Commission, the subject of the Emmy Award-winning documentary, Dawnland. You'll find the registration link for that event, as well as archive videos of all of our events on our website. Let me thank the Peace and Justice Steering Committee and Loyola's events team for assisting us with today's talk. I also want to thank Mary Catherine Bunting, whose generous gift established our program and makes the work we do possible. Following today's talk, we'll have some time for Q&A. We have some questions that students have submitted in advance that we'll ask on their behalf. There's also a comment box, so please feel free to submit questions as we go. Now, let me turn it over to my colleague, Dr. Heidi Brown, Associate Professor of French in Loyola's Department of Modern Languages and Literatures, who will introduce today's speaker.
Hi, everyone. It's my great pleasure and honor to introduce Dr. Collins Airhihenbuwa. He leads the interdisciplinary team known as the Global Research Against Non-Communicable Diseases Initiative at the School of Public Health at Georgia State University. He is also a professor of health management and policy. Dr. Airhihenbuwa is an expert in creating solutions to promote health equity in national and global health and has more than 30 years of experience advancing research on culture, identity, and health to inform strategies for training young professionals to conduct health behavior and public health research and intervention. He was the Dean of the College for Public Health and Social Justice at St. Louis University in Missouri, and he has authored a cultural model, PEN 3, that is used in several countries to develop programs and interventions to address health inequity. He has served as a visiting scholar to UN agencies such as the World Health Organization and major universities, including Purdue and Boston University. He has also served on the boards of the St. Louis City and Hospitals and National Advisory Committee of the Robert Wood Johnson Foundation Health Policy Scholars, the Global Philanthropy Alliance, and the Board of Scientific Counselors for the Centers for Disease Control and Prevention. Dr. Airhihenbuwa has authored more than 130 articles and books, and 6 books, and one of his recent articles is Culture Matters in Communicating the Global Response to COVID-19, which talks about how important culture is to an effective community-engaged public health communication and how to unpack the same messages globally differently across cultures and communities. He is the recipient of several prestigious awards, including the Scholar of the Year by the American Association of Health Education, the Symbol of Hope Award by the American Journal of Health Promotion, the Outreach Award by Penn State University, the David Satcher Award for Leadership in Reducing Health Disparities by the CDC and the DHPE, and several mentor awards. And I can say, just as a personal note, that Dr. Airhihenbuwa has really helped me in my research to mentor me as I was a grad student and talk to me about how to, just overcome fears and publish and move forward. And so I'm just so happy, so honored, and really excited to hear what he has to say for us, and to give him just a warm Loyola welcome as he gives his talk today. So I give you, without further ado, Dr. Collins Airhihenbuwa.
Wow, thank you so much, Dr. Brown, and for that very kind introduction. And it's actually, it warms my heart to to be invited by those whose life you've come in contact with and have been a part of, as I've known Heidi Brown for many years, work with my wife, and so she's a family member, I can say. And Dr. Keys for meeting for the first time and appreciating what your office does, and of course the work around peace and justice. So welcome everybody, and I think we'll get started. And so the way I like to start is, I often say that I am not the person you look to for solution. I'm the person you come to if you want to question the question, because I know that the question can be posed in a way that the answer is a given. It's inevitable. We experience this in the way we produce knowledge and the way we ask for issues to be addressed, or try to understand why people make the decision that they make. So the road and the traveler is something that I've talked about in many places as a way of trying to move the field of public health from this overemphasis on individual behavior rather than looking at the structure and context that shape those behavior, that allocate choices, in many cases, that the absence of choices. And one of the things that I enjoy sharing when I was a dean at St. Louis University was this journey of St. Ignatius of Loyola, the journey of a pilgrim. And I will often quote someone whose work I really cherish, and I'll just show you who, Mark Nepo, that really, at least for me, helped clarify the notion of what a pilgrimage is, the journey of a pilgrim. That being a pilgrim, to journey without change makes you a nomad. To change without engaging in a journey barely says that you are a chameleon. In order to engage in a journey for transformation, not only do you journey, you also have to engage in a change. There has to be some transformation occurring. And that is a part of what I want to talk about, not in the part of how the individual can be the focus of the journey, but to understand the broader context of the road, the different stops they may have to make, the vehicle that they need to use, and what really condition the journey so that we don't place undue emphasis on the traveler without understanding what condition their decision. So in questioning the question, there are three areas that I will focus on. And first is a blog I wrote last year where I wanted to address the nature of racism, that is not just a national issue. I mean, today we know that racism is being addressed at different levels, that in fact colonization is a part of structural racism. And that I'll talk more about that. For those of us who were born in different countries, we often say how we know how to become Black or become Black when we come to the US. But there's something repressive in the structure of colonization that can only be expressed and understood if you unpack structural racism. So that is one. The second is that as you begin to understand the way COVID sort of allocate differential burden to different population, you begin to see this intersection of racism and colonialism, and how to really understand common space, shared space that we need to create to address the disproportionate burden of COVID borne by Black and brown bodies, whether it's in South Africa, in terms of housing, whether it's in Brazil, in terms of colleagues that are working there looking at favela, who is engaged in public-facing job, and so on and so forth, that the same mechanism operate to create this division in terms of the impact of a pandemic on the population. And that to understand that, we then have to really not only think about the traveler, but more focus on the structure and the system and the road, and how it shaped the decision we make about risk mitigation, which I will talk about shortly. So to understand global spaces in terms of how you make the connecting road, I revert to three popular expressions that I use in my talk. One has to be, in this case, I'm looking at anti-racism and colonization, the intersection of the two. We say the African expression, until the lion produced their own historians, the story of the hunt will glorify always the hunter. So in deconstructing colonization and racism, the question becomes, how do we train the new historians to tell the story and to tell their own story? And this is why it's so important that in conversation like this, that we engage students as the new historians, who has to help deconstruct what is there, what we know, what convention says is, and what we can retain and what we need to transform as a part of understanding the structure of the road on which the pilgrim has to journey. And but in so doing, to understand what Chinua Achebe made very popular, that no one should enter their home through somebody else's gate. No one should enter there. His exact quote is, no man should enter his home through another man's gate. So the question becomes, when you are preparing the new historians, what gate are you preparing them to enter? How do we work with the new historians to understand what their home look like? It could be an intersecting space that covers a range of experience and identity. But, and if you do see that gate, would you recognize it? And of course, the last part has to do with a sort of self-affirmation. Do you know who you are without what you do? We are so accustomed in the academy to defining ourselves by a professional title, and we look for people who are in leadership position. But when we engage people in the community, this is not the level at which we engage them. So who are you at the level of personhood or multiple agency that embody those who with whom you encounter? Who are you without your degree? Because if you can understand who you are without your credential, then you're effectively saying that when you no longer hold those positions, then you are a non-entity, you are a nobody, but you are somebody. And who are you without your title? And all of this come to, in terms of the intersection between globalization, decolonization, and anti-racism, is what we are taught to remember, and I'll come to that later, what we learn to forget. There are things that we are taught to remember, and they are often based on what is going on, what we are experiencing. The question for me always is, what are we forgetting? And this is so true in public health. Today, before COVID-19, the opioid epidemic, which still remains with us and has actually been exacerbated in some situations because of the isolation and the mental health challenge that many people start facing because of opioid. That opioid was a system failure, not individual failure. system failure, not individual failure. It was the first time I saw a drug epidemic became a major concern to white family. The population that often saw drug use as individual failing. As we know during the crack cocaine epidemic, that it was seen as the failing on the Black and brown body that fell a victim to this epidemic. So the question is not an or, is what are we learning today about what happened in the past? Are we forgetting the way in which the road that we understand today in opioid epidemic, not the traveler, was also at play during the crack cocaine epidemic? I wasn't really the traveler, I was more of the road. And this is where we come to, how do we train new historians to understand that it is not an either or, is and. And later in the publication that Dr. Brand talked about, I did try to address what some scholars in business have called the tyranny of the or, O-R, and the genius of the and, A-N-D. But for Chinua Achebe, he put it simply that when one thing stands, another thing must stand beside it. That is saying that there is only one way is something that is so strange to many cultures, that it is not an or, is an and. So part of what the new historian had to understand is not about creating the only gate, but it's recognizing that there are other gates through which we enter the work that lie ahead for us. And in 2019, this book was published, and it was a seminal work in the sense that it was first time American Public Health Association would support a book that clearly has racism on its title, and several chapters trying to understand the nature of racism, how it operates. But more than that, the work that has been done up to this point in the field of public health, and how to unpack the structure and system of racism so that we begin to work collectively. And for those who are interested in public health, and I know some of the students are particularly interested, this is a book that I would highly recommend. We actually bought several of this book last year at Georgia State, and invited the lead editor, Chandra Ford, to work with the faculty and staff of the school and talk about why it's so important to confront racism within the academic setting. But of course, one of the work that the book talks about is critical race theory, and I collaborated with Dr. Ford in developing public health critical race practice. We actually looked at how you apply critical race theory to field of public health. But then last year, September, the former President Trump issued an executive order banning any federal government agencies' engagement in any effort to understand critical race theory. It led to agencies like CDC. I was actually in the middle of discussion with them to offer some training to their senior staff, and agencies had to pull back from engaging in trying to understand a theory that is trying to move conversation of racism beyond individual indictment into looking at the structure that reinforce and normalize this behavior in such that you could be a Black person heading an organization that promote the silencing and invisibilization of Blackness. You could be a woman being an organization that is engaged in policy that silences women. So the structure is what we are trying to focus on, the road. And so just briefly, the racism has been addressed by Kamara Jones, and that we're really looking at unfairly unfair disadvantages and unfair advantages, accumulation of advantages, accumulation of disadvantages, that when you have that, it is not just the hyphenated Americans that suffer, everyone suffers. That in fact, when we do comparative analysis, it almost assumes that whiteness is the ultimate goal or has this ultimate health until you place it within global analysis. I'll just give you some example. I'll get to the example, but basically Derek Bell, who's considered the father of critical race theory, really talking about how to understand society, the field, our personal life, and having this hard-eye, broad-eye view of what racism is and how it operates. Because it has a way of sapping the energy of everyone in society. So what we try to do in critical race, public critical race practice is bring this issue alive within public health. So a paper that was published 10 years ago, we actually had a 10-year anniversary conversation or webinar last year, was really to address this issue with issue of racism, the consciousness and orientation, the lexicon that normalize the work that we do that needs to be examined, and then the different stages that goes from semi-structured engagement to self-critical research approach that charity begins at home. One of the things that we have to learn to do as scholars is also examine how our behavior we become complicit in in reinforcing the system we challenge because we have not changed our own scholarly behavior. And that is, those are publications that I'm happy to send to Dr. Brand to send to those who might be interested. So there's been effort in different fields because critical race theory came out of legal field. There's been effort to try to understand how it applies, how it guides the thinking in other fields. One of the three key areas in understanding the road is that you start a conversation by focusing on those on the margin. Assess a priori bias. How is our research contributing to it? Why do we keep asking the same question around behavior? If that is why is it the only question we ask? Can we ask other questions? I have a colleague at Georgia State who was doing analysis recently, presenting in class about how to do some basic statistical analysis, but the example he used says white and others, and then some Black student raised the question, why others? And he brought it to my attention, the attention of the dean, and said, he's never really thought about this. So we have committed scholars who are open to that sort of engagement, that the idea that we have a lot of studies that was very comfortable by having a category of others, and it was white and others. But at the same time, at least in the US, we can start to have a breakdown even for COVID, but there are countries in Europe where race data are not collected. So the structure of the road is, as committed as you may be as a traveler, you don't have the instrument with which to break down the others. And then once you have the information, how do you engage in a counter narrative? Because the narrative is very important. The story is very important. So the counter storytelling is about framing spaces to breathe, to render what is important, what matters, not just what matters, but what matters to you, what matters to me, visible. And a part of that visibility is what led to the need to render visible not only what is conventionally seen as something wrong, but what is right. Is what led me to the development of the Pen 3 model. As a graduate student, anytime a conversation came around people who grew up in the villages like I did, the parents who were unlettered, because there is very, the notion of schooling conflicted with education is so common in terms of what we do. We we assume that if you are schooled, you are educated, or if you are not literate, you are not schooled, then you have no wisdom. So those were part of the things that I wanted to bring to the fore, that in every context, in every individual, in every space, there's something positive. And that is what you must begin. What are the cultural strengths? And to even go as far as saying, in measuring wealth, is it only in material possession? What are the cultural wealth? And that really is what gave birth to a Pen3 model. The idea that if you go into a community, to engage the community in a conversation around health, for example, could be non-communicable disease and others, the part of the conversation has to start with what are some of the positive, the assets that people have, so that when you're thinking of asset, it's not just material possession, the way in which people engage to address everyday issues or matters that concern them. And that if you can find those positive issues or positive attributes or value, then you need to leave, because you will become a part of the problem, because you are not questioning the question. You simply took the question that is being posed and you want an answer. You have to learn to question the question. And so that is in part of what we try to do in the article that Dr. Brown referenced, that there are conventional ways that we look at communicating about health, but there are a lot of it is very individual focused. It doesn't render it invalid. It simply means that it is not enough. That if we are dealing with social distancing, we need to be mindful of contexts where it is just not feasible. Is something that is related to what career you engage in if you're in public facing work, beginning with those who work the grounds at the airport that we often don't talk about, those who are in buses, who are driving buses, or public facing work. We hear concern about restaurants need to reopen. I also worry about I understand the need to restart the economy and the revenue lost, but I worry about those who are working in those environments, the employees that have no other options. So it becomes a question of prioritizing livelihood in a context where there are no safety net provided for those who find themselves in those situations. So it becomes a case of livelihood over the protection for their health. But in this work, we really try to drill down on this idea of an either or. Very early on, no matter what you think of the Chinese government, the earlier approach they employ was considered draconian, even by some of our leaders that we praise today in public health, that it was too draconian, and that is not really the way we need to address the issue. But the measure, whatever we call it, yielded the type of outcome that saved life. So the question is, it cannot be an either or. It has to be individual-based risk mitigation and collective-based risk mitigation. And that is what brings about the change that we have to see. And we begin to see some of that today, even though there are states, and depending on the political structure, states that are still resisting and begin to open up until we see crisis. So a part of it is sort of the social contract we have with our government and with the system in terms of what we believe is premium in decision-making about our life and about our health. So culture and color converge, and to teach us that Black Lives Matter. Black Lives Matter, and culture is important, but so is the need to address racism. It led to a second publication, another publication I had last year, which actually initially was a blog on my URI's website. It so happened that that really is the origin of one of the title that you see for this presentation. I was at the time, this was been around June last year, and I heard on the news, it was actually evening news with Lester Holton, and he was giving a recommendation that has been provided by experts in public health that in terms of risk mitigation, driving was safer than flying. And the moment he said that, I basically leapt up my seat and said, no, not for everybody, not for me as a Black man. And that I was planning to drive from State College to Atlanta in the next few days, and it would take me about 12 hours. I still do the drive. That in driving from State College to Atlanta, I'm going to pass several states and municipalities notorious for police violence visited on the Black body. So I have to think about my risk of encountering police in my drive against the risk of possible exposure to COVID-19. So while others are thinking only about social distancing, I had to also worry about police distancing. And so that was that the double pandemic has a differential impact on different populations. It's not an or, it's an and. And so with that, I took a drive to Atlanta, and of course my colleagues were happy. Those who had me talk about it, they said, well, that is not the point. You don't understand what the message I was trying to convey, that it is not actually the journey in itself, the choice that you make. It is that the context of protection and policing had an added stressor for me, that my calculus for traveling took a different dimension that had an added stress in way of trying to determine what is the best for me, what is the best channel for me to take. That those added stress, those daily nuisance, when you multiply, that is what led to shorter telomere, higher allostatic load, the NCD concern that we have, that persons that have this additional burden have, come from those encounters. It was my way of trying to say, if you were teaching risk analysis, that you ought to be looking at not just the condition itself, but the nature of racism that present this added burden to Black men in this case. So for a new historian, social distancing and police distancing had to be a part of the calculus. And then for other population, again, I say again that it is not a case that the COVID-19 or that the white population is the ultimate, that have the ultimate health outcome. That if we were to look at just ranking and life expectancy at birth, 1980, US was 11. And in 2006, was tied with Slovenia. 2018, 38, became 38, based on US UNDP figure. The point is, if we were to look at, because one of the questions that always come up with the risk, the risk profile for the US when you look at life expectancy at birth would be better if it were all white. Well, that is not true. The risk profile, I don't know if my picture page here blocks any of your view. In 2006, white population would have ranked 30th in the global life expectancy cases, and Black would have ranked 58. In 2018, white population ranked 36th, tied with Barbados, and Black 73. So if you're separating white out, the case of life expectancy shows that white population fare far worse than one would expect. We take the case of COVID-19. This is today's data. If we were to look at US, we do know that death rate clearly per 100,000 population is higher for Blacks and Latinx. But if you compare US white to Canada and Germany, what you find is that US white die at twice the rate of Canadian. So if we were focusing on individual behavior or decision that is not made, we will have to be making the case that somehow US whites are weaker or not as strong as Canadian. But yeah, that would be the case if you were focusing on the traveler. We have to focus on the road that structured the journey of the travel. And to do that, we have to use actual cases, going back to the heavier burden shouldered by Blacks. Susan Moore, a physician that died last year, and wrote about the encounter with her own colleague, or the physician treating her, who would not take her word for it in terms of describing what she was suffering from. So this issue of when people often worry about the extreme right wing, whether it's the January 6th insurgents on the US Capitol, there are many people that like to think about just focus on the right-wing whites group, but there are many ways that those with whom we work are actually engaging in behavior that undermine our own health. And that is what that article was really designed to do. So as James Baldwin has said, not everything that is faced can be changed, but if we are going to bring about any change, we have to face this issue. So schooling is not education. Many years ago, Ngugi wa Thiong'o, a Kenyan writer, this said that the child, in terms of colonization, the child was now being exposed exclusively to a culture that was a product of a world external to himself. He was being made to stand outside himself, to look at himself. For us, for the new historian, this is why we focus on students. We have to understand why a new gate is necessary to address peace and justice. And we focus on students because Frederick Douglass says it's easier to build strong children than to repair broken men. And those of us, I always said that professors are mostly broken men who only know one gate, and there are many who understand that and are trying to work towards identifying the other gates. But a part of building new historians is to reframing the question, reframe the methodology as we try to do in critical race theory, as I've tried to do in Pen 3 model, and make your voices heard. Silence will not protect you. The voices that we're hearing from Tennessee Coates, and who basically said that it was racism first before race, not the other way around. Brian S. Kendi that said that the notion of racism, continental racism, started in Europe. It's not a new phenomenon. We have to go back to the history. Or for some of us who read Things Fall Apart at home in Nigeria, in our spaces, and not really understand the full nature of what he was trying to convey, that we were confronting a system that believe in the tyranny of the or. It has to be what comes in, not the genius of the hand, rather than what comes in addition to what is there. That Toni Morrison teaching us that in terms of trying to understand the notion of self-regard, there are important questions that we must ask ourselves, and we have to be bold enough to question the question. Or as Isabel Wilkinson is making the case in the new book, Cast, that there are structures that are global that organize who is in the margin and who is at the center. All of this simply means, as Audre Lorde discussion, that your silence cannot protect you, will not protect you. You have to have a voice. To have justice, peace, for the new historians, the part of it is to not understanding how not to stand outside yourself, to look at yourself, and why it's important to seek leaders committed to supporting voices, the voice for peace and justice. And to achieve global peace, we have to engage in anti-racism and decolonization. And we do so through identity, know who you are, and relearning your gate for what is there and not always what is missing. Affirmation, creating spaces for seeing and being seen, visibilization, and narrative that focusing more on the road and the structure rather than the traveler whose journey is already framed by the structure of the road. And Brown Stevenson, this powerful voice in social justice, have often said that one of the key ingredients in bringing about transformation is proximity, get closer. And what I say is that the getting closer allow you to also journey towards yourself, drawing from the Native American expression that the longest journey you ever take is the journey towards yourself, the head and the heart journey. How that being proximate allow you to re-examine and re-engage and while you ask yourself the question, who am I without what I do? And understanding that reframing means questioning the binarism that you may have been accustomed to by thinking that the opposite of poverty is wealth, but Stevenson is saying that it's not. The opposite of poverty is justice. So fighting for peace means imagining the world differently. If you were to come to my office, this is how you see it, but it said the word upside down, but to me, the word is normal this way in terms of depending on where you come from. We've learned this from African leaders of the past. We face neither east nor west, we face forward. We prefer self-governance with danger to servitude in tranquility. It's basically the story of a pilgrim engaged in the pursuit of peace, Kwame Nkrumah. And that the notorious RBG wonders that you have to fight for things that you care about, but do it in a way that bring people in to have conversation. It may be difficult conversation, but nonetheless, it's a conversation that must be had. And for peace, equity, and justice, we have to not be afraid to get into, to make noise. As John Lewis who said, get into good trouble, necessary trouble. So as my last slide, I'm not sure how I'm doing on time. What I wanted to leave you with is more of a story of what does that really come to in a nutshell for you as far as engaging in a conversation or a walk around peace. When Toni Morrison received the Nobel Peace Prize, and the lecture on the acceptance of that award started with a story of this woman who was at the outskirts of town, probably pushed there because of a number of reasons that define her marginal existence. But the story is that the woman was reputed to be wise and knowledgeable, but blind. So some young people went to see her just to play pranks on her, but at the same time to try and test her wisdom. So they decided that what they would do is go in front of her and ask her a question. So they present before the woman and said, woman, we are told you're wise and you have this wisdom. So the leader said, well, in my hand is a bird. You tell me, since you are wise, is the bird dead or alive? She thought for a minute and reflected, and then finally responded to the children that I don't know. I don't know if the bird is dead or if the bird is alive. But what I do know is that the bird is in your hands. The bird is in your hands. All you need to do is replace the bird with peace. Whether it's crumbling, whether it's alive or dead, the bird is in your hand.
Well, Dr. Airhihenbuwa, thank you so very much for your words of inspiration, your words of challenge. You have condensed decades of wisdom, activism, moral vision for the benefit of all of us, and couldn't be more grateful for everything you shared. And really for your monumental contributions to your field, for giving us images that we will not soon forget, moving from the traveler to the road, entering a new gate, the genius of the and instead of the binary of the or, daring to question the questions, appreciating social versus police distancing, and your incredible personal story. So thank you very, very much for everything you shared today. We have some time for questions. A lot of students are with us, and some have submitted questions in advance that Heidi and I will share. There's also a Q&A box. So let me invite anyone who is listening in. If you have a question, please, we'd love to hear from you. Enter that into the Q&A box and we'll ask it on your behalf. We have several students who are inspired by your personal story. And one student asks, in your life and career, what is a case of health inequity that impassioned you the most? Was it a case of medicine or surgery or something less visible like poverty or misinformation? What made you want to act? We have another student is asking, what is something you've experienced to be an unexpected obstacle or common problem that maybe wasn't as obvious prior in your field of work? You've touched on some of this in your talk, but do you want to share a little bit more about that personal background as your entrance into these issues?
Absolutely, thank you. And thanks for those questions. I shared with you what led me to develop the Pen 3 model. And of course, as a student, you do what you have to do before you graduate and do what you want to do. My idea was see that as a student, as I observe what I consider to be not just a misunderstanding, because I had great professors. I don't think they were intentionally framing the space where I grew in ways that made me a stranger in that space. I think I just felt that they didn't know better. And part of what I had to do was to read beyond public health, read materials outside of health to understand how we tell story and how we create narrative. Some of the earlier work was lessons in traditional healing, specifically that relates to health, because we know that, in fact, in my book, I've illustrated not just the medicine itself, but the sort of ethical position that healers take about the role of money in the work that they do, how it could corrupt the work they do. And today, everything is monetized. So there was great wisdom first in the sharing power. So letting you know something happened again, this is what you are supposed to do. And then secondly, where the proximity that we talked about, they were the ones that were around. In fact, when the World Health Organization started pushing for years ago, Health for All by the year 2000, we need to focus on primary health care. It was very clear that they wanted to incorporate traditional healing practices into the work that was being done. Acupuncture today is seen, and some of the work that many of you may have engaged in, including the science of Ayurveda, they all came from the margin. And to this extent that people use these services because of proximity to the work that is. So that greatly influenced what I did and what I wanted to write about, recognizing that it is not all well with practices. We don't want to romanticize that because it's traditional healing or it's Ayurveda is perfect. It simply means that it's not an all of allopathic or this, it was an and. that there are positions that they occupy in addressing basic health needs that people have. Whether it's my own personal illness or coming to a clinic where I know they also didn't have all the answers. So these are experiences that continue to shape my own thinking and in working in this area.
Thank you so much. So I have a question from a student. I know that you usually travel all over the world. And so their question is, how does the study of public health differ from culture to culture? Are there certain universal truths when it comes to public health that stay true no matter the place, culture, or environment?
So the excellent question. The first answer to the last question would be, I don't really believe in the notion of universal truth. And that is why when I shared Chinua Achebe's expression that when one thing stands, something else must stand beside it. And I think the universal truth is what speaks to this tyranny of the all. So if you approach, does that mean that there are no shared value? No. Many culture, when you have an illness, first you want somebody who is going to help you take care of that illness. As we have COVID-19, we know that social distancing, when it's possible, help with risk mitigation. But at the same time, the differences in country is shaped by, in part, the political economy of the country, how people have come to understand and appreciate what they consider to be normal within their government or their system. So if you are in a system that we tend to see as totally socialist, so there's this communitarian logic that everyone embrace, even as some might question the absence of freedom in having individual choices. But if you are in a system like ours in the US, you buy into this individuality unless when we start talking about Social Security and all the other programs for which the framework is actually social, and that social is not necessarily negative. So I think when you go from country to country, the first thing to try to understand is what is the political structure? What is the social contract between the government and the state? Why is it in England, the health services can almost mandate certain behavior and everyone follow, or in France, and then in the US, when you do it, it becomes this question of what you subscribe to in terms of how you understand governance and responsibility. And even within the US, it varies from, don't go outside the country to understand differences in the way we understand health and public health. If you are I was in Missouri for years, and Missouri pride itself in challenging government. And so the municipalities that were created where you have this huge gap in health outcome, wide disparity. You can be driving 15 miles from Clayton to the airport and pass several municipalities. And the more separation and differences you have in governance, the more inequity you are going to see, even within the same state. And that is what one has to look for.
Thank you so much for that. And a number of student questions address this issue of health equity. One student notes, your real leadership on non-communicable diseases. So the student asked, what kind of overlap have you seen between the prevalence of non-communicable diseases and the presence of social injustices?
Oh, excellent question. The example that I gave was in part to call on our colleagues to reframe our approach to understanding disease outcome. One of the things we are dealing with COVID-19 that is a concern to me is the degree to which people are now even more limited to engaging medication adherence, because if you're on medication for, say, hypertension or diabetes, it is expected that you are going to have a periodic checkup to check your blood work and see how well you are responding to medication. Are there some contraindication? That requires scheduling meeting to go see a physician. It requires doing the sort of thing that COVID-19 prevent individuals from being able to do. So what you will end up seeing, we're going to see cases of people, not even those who were following their regimen, not being able to do so because of COVID-19. And so what COVID-19 did was actually to reveal the structural racism and structural determinants of health that we've talked about not really wasn't well understood in ways that we can understand it. For us to deal with hypertension, diabetes, stroke, asthma, we have to begin to understand the structure better that create vulnerability to those conditions, and that makes it difficult for people to follow medication or medication adherence. The other thing about medication is if you have no job because of this public-facing job dwindling, restaurant, the last thing that individuals are thinking about is buying medication or filling their prescription. They're thinking about what to eat and when the next and where to live.
Thank you for that answer. We have a question here on COVID-19. It says, what are your thoughts on the ethics behind the COVID-19 vaccine distribution and research?
Right. There's been question about vaccine hesitancy and what impact that might have on being able to bring the pandemic truly under control. And not just in the country, globally, because if you have a sizable number of population not vaccinated, it still presents a great threat to the population. So it goes back to the history of institutional trustworthiness or the lack thereof, because of medical atrocities that were visited on the Black body. It's not just the Tuskegee or the US public health syphilis study that is notoriously called Tuskegee syphilis study. It's really a US public syphilis study that was visited on population of Tuskegee. It goes back to medical apartheid is quite clearly documented. A number of these practices where medical institutions were just not responsive to the needs of Black. I showed you an example of Susan Moore earlier. So that then creates the absence of trust for medical institution, which is actually at the foundation of the question of if I go and get vaccinated, is it going to be different for me, or am I getting the same thing? Because I know that it's not always, we don't have equity. First is access. Do I have access? But if I do go there, could I trust the medical provider to provide me with a vaccination that I know is good for me? That is something I see COVID-19 as an opportunity to build trust, because the trust is broken. And to bring about trust, we don't focus on people who distrust and say, why do you distrust? We focus on the institution that create absence of trustworthiness and say, why do you create the context and environment that make people not trust you? So the work has to start from institutional level, institutional point. I applaud leading public figures getting vaccination publicly, and just as a way of encouraging more Blacks and Latinx population to go for vaccination when it becomes available. I will go for it when it's my turn and it becomes available. However, I have talked to physicians, nurses, public health workers who still hold out this concern, are still hesitant, in part because of The story, Susan Moore, is just one indication that there is still this question of will it really be safe? Will it really, this institution that has not always been forthcoming, where I wasn't treated right, how do I trust that they are actually going to do right by me this time? So that we have to take seriously and work to build that trust.
Thank you very much for that. You spoke in your talk about, the importance of seeing structures. So if one student who's interested in, what that means for community outreach. A lot of our students are engaged in community service learning. So one student asks, what community programs could help increase the overall health of a neighborhood or a specific demographic? Can you speak to a little bit about what effective models of neighborhood-based outreach could look like?
Right. First of all, it helps if there are structure in place to have that type of engagement. One of the things that I'm encouraging my students to do in Atlanta, Maynard Jackson as a mayor created this neighborhood planning union. There are 25 of them around Atlanta. It was created to give people in different geographic spaces to have a conversation, whether it's about zoning, about what happens in their neighborhood, safety issue, are there lights next to the bus stop, and so on and so forth. There are students, and I teach a class on health disparity where I ask students to join the one in their own area. And if they are coming into Atlanta and they are not, if people commute from outside the city, to find meetings in their community. It could be a school board meeting. Just attend community-based meeting and begin to listen to some of the issues that people are dealing with, that people face in that community. And then as you listen, then you can begin to identify how you might bring your own interest to the attention of that group, while you are also helping to respond to some of the things that the group would like people to respond to help address. So if there are existing structure, I would say tap into that. Community-based participatory research was designed to engage, to encourage this type of what we like to say in university environment, the town gown alliance or partnership. But what I have found to be effective, I remember visiting Minnesota to do a lecture at the University of Minnesota Medical School some years back. And what my colleague there had done is he had been partnering with a community, they called them the Backyard Initiative, a community-based organization in St. Paul. And so I was asked to go meet with the group, and the group asked me to talk to them about what I do. I shared my view, and they invited me to come back to their breakfast meeting. It was at that meeting that even my host realized that the community had their own model. And the reason they invited me was that when I presented the Pen 3 model, they said it aligned with their own thinking. How can we work together? So I think what is difficult is when there is no existing partnership, and partnership is brought on because you want to meet with them to solve their problem. And they are looking at you and say, did we tell you we have problem for you to solve or to, but if you have that, which I gave the example of going to existing community meeting and basically listen, what are the issues, what are the priorities? Where do the priorities I have fit into what they are doing? How can I make contribution to what they already prioritize while I bring their attention to the health interest that I have for the community? That to me is what I've known to be most effective.
Thank you. I actually have a personal question, or not one from me. In my work on trauma, I think a lot about silence and silencing. And I was wondering if you could talk more about how do you unlearn silence? You talked about deconstruction. How do you what are the practices that like the ways of thinking and the ways of being that help to deconstruct narratives that have been already written.
Right. I think that to me is where the traveler becomes you. So you're not, because in public health, we try to think about other population that things happen to. So when you get to that question of who am I without what I do, that to me is when you become the traveler trying to understand the landscape. It requires, peace requires fight. You always hear people say fight for peace. Fight, just because we say peace doesn't mean you are passive. It requires fight. But coming to voice require fight. Sometimes it's a mental fight. Is because you are really branching out of a zone within which you may have found comfort, but that you feel that it's no longer tenable if you are to maintain a certain, not just sanity, but be able to advance. So what I recommend is reading beyond one's discipline and begin to understand how the those who are been laboring in this space address how they address it, how they come into their own agency in addressing, in no longer being voiceless, in coming to voice. I draw a lot from the work of Toni Morrison, Chinua Achebe. There are in fact, I'm writing a piece now where I talk about people whose work. I do Frantz Fanon, "Oh, my body make of me always a man who questions." And Sheikh Anta Diop that basically said that when you take a different route, the criticism become about you, not what you are presenting. I know that very well. It's just reading about the journey of pilgrims, those who really engage in, not even a conventional way one may understand pilgrimage, that it does require work to come to voice, because the moment you come to voice, you are no longer in that space of being silent, and you have to nurture it. And then you also have to seek and work in the space of those who will help you achieve a more audible voice than what you may have yourself.
All right, thank you for that. We got time for just about one more. We've got a question coming from the chat here. What do you think about non-certified vaccines from some countries like China, India, Russia, now given to some countries in sub-Saharan Africa and Latin America? Who can stand against that? This is another injustice in COVID-19.
Yeah, it's really unfortunate when we have a global pandemic. There are going to be different forms of remedy being promoted. I spoke to a colleague in South Africa last week who felt that at the time that South Africa stopped the vaccine that was coming from the one-dose vaccine that was reported to be less protected of the South African variant. So the government, even though they had actually put in an order for, I'm not sure how many, I want to say million plus, they stopped. I think it's AstraZeneca's, I'm not sure which one. So when they stopped, countries, India, China, approaching different countries to say, look at ours. So what is very interesting is, in terms of not certified, we know FDA certification. Russia had vaccine that they claim is effective. One of the things that we all don't always know, which is a challenge in global health space, is we know what we know in this country, where at least we try to believe that we know what we know. We also don't always know about some of the medical atrocity committed by vaccine company in other countries, as was the case with Nigeria and one of the vaccine manufacturer that vaccinated a number of children in northern Nigeria, and they end up either dead or this is for a different condition, or disabled for life. So there are those memories that rest with people that also lead them to not trust and believe that the vaccine will work. But the challenge for the countries that do not produce their own vaccine is how to validate the accuracy of the report that what is coming from other countries actually work. That is number one. And secondly, to validate that even when a vaccine is coming from a country like the US, that they are actually getting one that are viable, because you need cold chain for a number of these vaccines to be effective. We have cases now of vaccine center asking people to come in and get quick because the refrigerator has gone bad. So the issue really goes, it talks about the burden on the shoulder of those who have to manage these things in the global south, because they are dealing with not just what is normally approved through the US standard, but even the one approved coming into the country without, when the country may not have the sort of cold chain mechanism, guaranteed electricity and all those things to ensure its effectiveness as is expected in this country.
Thank you so much for all your thoughtful answers. And I want to just say thank you to everyone who came. Thank you for all the questions. Thank you to Peace and Justice Studies for hosting this talk. And we look forward to seeing you all again at our next one. Thanks, everyone.
Thank you.
Bye.
Bye-bye.